Hi, guys. Welcome back for our daily practice questions. It is day 48, and as always, I like to first get into my introduction and disclaimer before getting started with our questions for today. So, for those of you who are familiar with me, hey, y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock, a family nurse practitioner and the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, review books, digital flashcards, Q banks, one on one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. Now, y'all know my disclaimer and reminder is that we know there's no absolutes in medicine. We treat on a patient by patient basis, and any of the questions that you see here, I have designed and created based on the current guidelines that are being tested on the ANCC as well as AAMP exam. Now, any of my videos where I teach on things that we're currently doing in practice, I will always say that so there's no confusion. So, with that being said, let's get into question number one for today. Question number one states a 62-year-old male patient with a history of hypertension presents with a blood pressure of 148/92. His medical history includes obesity and a family history of hypertension. The patient has no history of diabetes, cardiovascular disease, or kidney disease. According to the ACC and AHA hypertension guidelines, what is the recommended initial treatment for this patient? Is it A, lifestyle modifications only, B, thiazide diuretics, C, ACE inhibitors, or D, beta blockers? Take a moment and tell me what you got in the comments, y'all. All right, so y'all know I always recommend reading the stem of the question first, as it allows you to slow down to ensure you're answering what is even being asked of you. So here the stem of the question states, according to the ACC and AHA hypertension guidelines, what is the recommended initial treatment for this patient? All right, so we're talking treatment for hypertension, right? So let's run it back and see what's going on with this patient so we can see how to follow the guidelines and treat accordingly. So we have a 62-year-old male. He has a history of hypertension. Blood pressure is 148/92. We definitely know medication needs to be initiated because regardless, even for healthy patients who don't have any comorbidities, if the blood pressure exceeds 140/90, we start medication therapy, right? So he does have a history of obesity and a family history of hypertension, but he does not have diabetes, kidney disease, or any cardiovascular disease. So there's no reason that he should not have certain medications. So we can utilize our starting four, right? So we can do, as I say, the first line therapy, your thiazides, your ACEs, your ARBs, your calcium channel blockers, with thiazides being the captain, meaning thiazides are the top of that first line therapy list, right? Unless there is something that is saying that you cannot give that. There's nothing telling you to eliminate the thiazides. So in this scenario, B is your best answer. You go with your thiazide diuretic. All right, question number two. A 58-year-old female patient presents for a routine checkup. Her LDL cholesterol is 155 milligrams per deciliter. Total cholesterol is 230 milligrams per deciliter, and her HDL is 50 milligrams per deciliter. She is otherwise healthy, no diabetes or smoking history. According to the cholesterol treatment guidelines, what is the most appropriate treatment for this patient? Is it A, no statin therapy needed? Is it B, high intensity statin therapy? Is it C, moderate intensity statin therapy, or is it D, lifestyle modifications? Take a moment and tell me what you got in the comments, y'all. All right, so stemming the question here, according to the cholesterol treatment guidelines, what is the most appropriate treatment for this patient? So let's see what's going on. We have a 58-year-old female. Her LDL is 155 milligrams per deciliter. You know we want this less than 100. And if they have two or more comorbidities, we want it less than 70, right? So less than 100 is that standardized goal. So we are definitely exceeding that. Total cholesterol is 230, and we want the total cholesterol to be less than 200, right? And then the HDL is good. Her HDL is 50. For women, we wanted 40 or greater. For men, 50 or greater. So we're actually in a good range for her HDL. Now, according to the cholesterol treatment guidelines, we know when the LDL is at bad cholesterol. So we want to focus on statin therapy to bring that down, right? And 155 is over it. It's not significantly over to the degree that we would need. And let me walk this down based off our answer choices. You can eliminate D because we need to do more than lifestyle modifications. A says no statin therapy. We know we can eliminate that as well because we definitely need statin therapy. The LDL is well over the goal range. Now you're trying to determine if you need a high intensity statin or a moderate intensity statin, right? Well, the high intensity statin will reduce the LDL by 50%, right? Although that's good, that's not the reduction that we actually need. At this point, that's not, we don't have to go directly there. We can advance there, but that's not where we have to go immediately, right? So you want to consider your moderate intensity statin so that we can have that 30 to 49% reduction, right? Um, you also could have utilized like a lower intensity statin because it's less than 30%, but that moderate intensity statin would be the best bet for this patient, just simply because when you're trying to bring it down, let's focus on math here. Less than 30% is not going to give you the reduction that you need. Because think of it's 10%, that's going to be, anywhere from 10 to 15 points down, for lack of better words, right? So we're still not where we need to be. That 30 to 49% reduction would put us exactly where our goal is for LDLs. So the moderate intensity statin is your best option in that way. But remember, it just goes up. So low intensity statins reduce by less than 30%. Moderate falls right in the middle, is anywhere from 30 to 49%, and high intensity statins lower it more than 50%, right? So the moderate in this scenario would be the best. Also, even if you didn't know that, process of elimination puts you there, right? All right, and question number 3. A 60-year-old female with a history of chronic heart failure presents with worsening symptoms. She reports increasing fatigue and shortness of breath after walking 1 block. She can perform ADLs but experiences difficulty with any physical exertion. Based on the patient's symptoms, how would you classify her heart failure according to the NYHA classification? Is it A class 1, B class 2, C class 3, or D class 4? Take a moment, tell me what you got in the comments, y'all. All right, so stemming the question here, based on the patient's symptoms, how would you classify her heart failure according to the NYHA classifications? All right, so let's see what we got going on. 60-year-old female, she has a history of CHF. She presents with worsening symptoms, reporting that she has increasing fatigue and shortness of breath after walking 1 block. She can perform her normal ADLs, but she does experiences difficulty with any physical exertion, right? Y'all, this is class 2. So B is your best answer. So let's walk through it again. Y'all know I always tell you when you have a range, know the lowest and the highest, and the rest falls in between, right? So class 1, although they have CHF, they don't have any limitations. So no limitations. Whereas class 4, they have CHF and they have limitations all the time, meaning while exerting themselves and at rest. Now, class 2 and 3 are always the areas where everybody kind of, it, but struggle to identify, like in scenarios like this, right? So class 2, prime example here is she isn't noticing worsening symptoms, meaning that she's short of breath when she's walking a block, exerting herself a little bit more, right? But she doesn't have trouble with her ADLs. So it's some slight limitations that we're starting to notice, but not to the degree that even when she's just doing her basic activities of daily living, that she's noticing that. That's class 2. Class 3 would be, hey, she's experiencing that shortness of breath when trying to do her ADLs and when she's exerting herself. You know what I'm saying? So class 1, no limitations. Class 2, when really exerting yourself to a degree that you would start to uh, normally have some dyspnea, but not to this degree. And then class 3 is, hey, small things, any exertion, you start to have those definite limitations. And then class 4, you have limitations when exerting yourself and while resting. So all the time. Okay. All right, you guys, I hope you found this helpful. As always, be sure to like, comment, subscribe, and share with whomever you may think may find this beneficial as well. But y'all know what to do. Y'all make sure y'all meet me back here. And if you need any other resources that I do offer, feel free to reach out to the Nursing Studio by giving us a call at 803-400-6864. You can also shoot a text message to this number or shoot us an email to thenursingstudio, the number 1, @gmail.com. Everything that I do offer is linked in the bio of this channel, including my website. And as always, if you're looking to book any of my one-on-one sessions or custom packages or plans, I always say either call, text, or email because I prefer to speak with you first so that I can gauge what you truly need to make sure you're booking the appropriate session type, okay? All right, y'all. Y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye, y'all.